Hello, this is Dr. Amy Toon, and I'm going to be talking about ears, nose, and throat examinations. When you start the ear, nose, and throat examination, you're going to go ahead and start with the head and talk about the anatomy and remember to think about the anatomy and the physiology and review of the related history, examinations, and findings. Some of the questions you would like to ask is a present problem or what brings them into the clinic today. And things that would happen under this category would be a head injury, headaches, stiff neck, thyroid problems, past medical history, could be head trauma, treatments of around the head and neck, surgery, seizures, thyroid problems, personal and social histories such as risk, intentions, nutrition, alcohol, or drug use. And family histories like headaches, as over 50% of migraines are familiar, as is the same with thyroid problems. Special populations are going to be your infants, pregnant women, and older adults in most of the categories of assessment. And one of the things you want to ask about infants is the prenatal history. You want to find out if they had a 3-vessel cord or a 2-vessel cord, and because that's going to lead to a lot of problems with the ears and the kidneys if they just got a 2-vessel cord. And look at the birth history, unusual head shapes, the quality of the head control and the strength, and acute illnesses, congenital abnormalities, neonatal screening for congenital hypothyroidism, and that's usually done if they were born in a hospital. If they weren't, they are to go to a pediatrician and be tested for hypothyroidism, and the reason behind this is untreated hypothyroidism for 6 months can lead to mental retardation. So this is a test which is often repeated. It's first done in the hospital when at birth, and often repeated on that 2-week visit, so there will be none that falls through the cracks. Pregnant women, you want to ask them about weeks of gestation or how many weeks they are postpartum. If they had any pre-existing diseases prior to being pregnant, if they had a history of pregnancy-induced hypertension, alcohol use, drug use, medications, both prescription and over-the-counter. And with the older adults, you're going to look at if they're dizzy and if they have head and neck problems. With hyperextension of the neck, it's not that unusual, especially if they're flexed at the waist and hyperextended at the neck, to have problems with dizziness. And that will happen as the cervical canal gets more arthritic as they age. The equipment you're going to need for the examination are tape measure, stethoscope, a cup of water to be able to feel the thyroid when they swallow, and some kind of transilluminator. The skull is composed of 7 fused bones, 2 frontal, 2 parental, 2 temporal, and 1 occipital bone. It has facial cavities for the eyes, nose, and the mouth. And when you look at this skull, you're going to realize that there's suture lines, and these suture lines are not going to totally ossify until adulthood to allow the brain to grow and the skull to move with it. The skull is these bones right here that are movable, that are these are the names of the bones of the skull. And the mandible is the one movable bone. Major landmarks of the face is the nasolabial folds and the palpable fissures. Facial muscles are innervated by the cranial nerves, 5 and 7. You have a temporary artery is the major accessible artery of the face. So I just wanted to let you see right here the palpable fissures and the nasolabial fold, or some people will call it the sides of the smile fold. What you want to do on the face is look at the head position, facial structure, symmetry, cranial nerves, and skull size and shape, the scalp and hair, temporal areas, and salivary glands. You're going to percuss the skull if indicated. For some reason you think that, especially in an infant, you would percuss that if you're concerned about hydrocephalus. And you're going to auscultate only if indicated, and that would be on the temporary artery. Just to review, here is the anterior view of the major veins of the neck and also of your thyroid cartilage. You realize when you look at this picture that if you're having any tracheal tug, what you're going to worry about is that they've got some kind of aneurysm, aortic aneurysm, because you can see the arch of the aorta is very close to the trachea. So if they have an aneurysm, a tracheal tug, especially if it's got pulsations to it, you're going to think aortic aneurysm. You realize that you're going to have the thyroid gland, and one of the main veins that go right by it is the internal jugular vein, and that drains into, lost my pointer, it drains into the subclavian veins, right and left. Side view of the throat, just to get your positions. The hyoid bone is at the very top below the mandible. Your thyroid cartilage, cricoid cartilage, thyroid gland, and your trachea. When you look at this picture, you realize you've got the clavicles right about in here. The other part of this picture that's cut out is the sternocleidomastoid, and realize that you've got an internal carotid artery and an external carotid artery that is on the side of the neck. So you want to palpate and inspect. First you inspect, then you palpate, then you percuss, and the last thing is you're going to do deep palpations. You don't really auscultate the neck outside of the buries in the carotids, except if they're having pain when you touch the temporal area, and then you're listening for a bury there over the temporal artery. You will also listen for a bury over the thyroid if you find an enlarged thyroid. And that's why I'm leaving auscultate out for the head. There's symmetry of sternocleidomastoid. You want to make sure it's the same on both sides. And of the trapezius muscle, if there's alignment of the trachea. And you want to look at the range of motion of the neck and palpate the lymph nodes. So you need to know your anterior triangle, and it is divided by the sternocleidomastoid, the big muscle between the ear and the sternum. And the posterior triangle will be behind the sternocleidomastoid and above the clavicle. The head, you observe head position, if it's tilted, if there's a tremor. You inspect the scalp and scalp for the size, the shape, the molding of it, symmetry, lesions, and trauma. You want to inspect facial fissures, including the following for symmetry and shape, unusual features, tics, characteristic facies, and that would be facial expressions, or not expressions, facial characteristics that would be typical of certain disorders, is what they're indicating there. Pallor and pigmentation variations. And an example of that would be your mask of pregnancy, would be one of your pigmentation variations, or rosacea. You also want to palpate the head and the scalp, noting the following for symmetry. If there's any tenderness, particularly over areas of frontal and maxillary sinuses, if there's scalp movement, if the sutures or the fontanelles are closed. Now you realize the posterior fontanelle will close by about 2 months. So even babies remember to cover their back. They do their posterior first. The anterior will close. It's a much larger fontanelle. And it will close about 2 years old. It's not unusual that you might feel the fontanelles, and you want to make sure that they're not bulging at any time. Bulging outward. You want to look at the hair, the texture, and the distribution thereof. And when you're looking at the hair, realize that one of the main reasons that infants lose hair is tinea capitis, and a fungal infection of the scalp is what that is. And there's assorted reasons why adults lose hair, and there's the male pattern baldness that has temporal loss and over the crown of the head for male pattern baldness. And there's thyroid disorders will also cause you to lose hair. The other big thing that's going to cause you to lose hair is if you've had any kind of major stress, any burn, a really bad acute illness, chemotherapy, the hair will come out. You want to find out if it's coming out all over or just in one location. And if it's just on the predominant side of particularly children, particularly girls, sometimes they got trichotillomania where they're twisting their hair, and it looks like they're pulling it out, but they're breaking it because they're twisting it. Another reason why hair falls out is with over-tension of the hair follicles, and they break. And this happens when some girls braid their hair very tight, or some boys braid their hair very tight. And as they undo these braids, or while they're braiding them, they break the hair. Okay, back to the head. When appropriate, you're going to auscultate the temporal arteries and palpate, noting the following: thickness, hardness, or tenderness. And on the temporal arteries, if you palpate the temporal arteries and there's any kind of pain there, you need to take note of that, because you don't want to let temporal arthritis go on. You treat it with steroids, but if you let that go untreated, it can end up in blindness. So it's pretty serious. You need to jump on that. You're going to inspect and palpate the salivary glands, transilluminate the skull of infants with a rapidly increasing head circumference. So what's rapidly increasing head circumference? Well, if you remember the head circumference chart you get from the CDC, the Center of Disease Control. And if everybody's got a line or trajectory that their head circumference should be going on. If for some reason their growth does not stay along their line and goes to the next line up, you need to really palpate that scalp and make sure there's no edema on it. Talking about edema on a child, or actually an infant's brand new baby, just delivered. Will their scalp have a little edema? Often in the presenting part when they had a vaginal birth. And that tends to go away in days. So by the 2-week checkup, when most nurse practitioners will be seeing the child for the first time, that edema should have abated. All right, you want to palpate the thyroid gland for the following: size, shape, configurations, consistency, tenderness, nodules. If the gland is enlarged, auscultate for bruits and evaluate the range of motion of the neck. And you're going to flex, extend, rotate, lateral rotation of the neck. The thyroid gland. Inspect and look for any enlargement. Normally, you're not going to see the thyroid. Realize, however, it's a normal finding. If you are able to palpate, realize the right side can be 25% larger than the left side. And that's a normal finding on people. That doesn't mean that there's anything wrong, but the right side tends to be a little larger than the left side of the thyroid in most people. Your auscultate if enlarged or nodule and see if you hear a bruit. To be able to hear better, though, it's easier if you just tell the patient to hold the breath, and you'll be able to hear better. You should not hear anything. But if you ever hear a bruit, it will sound like bruits, like on fistulas, it's just a sound, which you normally wouldn't hear. So here's how you can do a thyroid exam from the posterior. And what I do is most people have two lines in their neck from their skin folds. Put your fingers flat in between those two lines of the neck skin folds. Pull them back, just pull them straight back, and then you're going to deviate the trachea and the thyroid to one hand or one side, and you're going to palpate with that one side as you have the patient swallow a little sip of water. You should feel the thyroid. It might just go up and back down, and you're trying to see, is it symmetrical? So how big is this thing, and how thick is the thyroid? If you will imagine the size of a quarter and the width or the thickness of a quarter that just slides up and goes down. It's about that size. Okay, if you want to do the anterior, and this works better with small children because they don't like to have their neck grabbed, and for people with psych disorders that might have anxiety and they don't like you to go behind them and grab their neck, you're going to do an anterior approach, and you're doing the same thing, but you're using your push to the left with your right thumb, and your palpate with your left fingers. And you're going to still try to feel the exact same thing. In this picture, she's using her left thumb to palpate. I use my fingers because if I use all four fingers, I got more surface to feel than just my thumb, and that's why I use my fingers. In this picture, I think everybody can see this is a quite enlarged thyroid. The right is bigger than the left by a lot more than 25%. And this is a lady that's got obvious goiter. And we don't know if it's iron deficiency, but that's a strong suspicion. Special populations on the head. You're going to, infants, remember the head circumference. Remember the fontanelles. The posterior fontanelle closes at 2 weeks. Anterior at 2 months. I'm sorry. I said that wrong. The posterior at 2 months. The anterior at 2 years. Look at the suture lines. Look to see if they've got any kind of cephalohematoma. And a cephalohematoma would be a blood underneath the skin or the scalp, but it doesn't cross any suture lines. And you transilluminate that if needed. Children, palpate the skull, note shape of the skull and thyroid gland. Pregnant women, chloasma is a word that I've always wrestled with. Chloasma is the pregnancy mask, and you're going to see a darkening And this usually happens around week 12 of pregnancy, and it tends to be a darkening of the pigmentation of the face, often on the forehead. They can have thyroid enlargement and a bruit with pregnancy. On adults, realize there will be sagging facial musculature and decreased range of motion of the neck. They can have a fibrotic thyroid. Everything gets kind of fibrose as you age. And hyperextend the neck might cause dizziness, especially if they're bending over. That's pretty typical. All right, headaches. There's different types of headaches that we're going to cover. And the headaches basically are going to be a little later, but it comes down to headaches can be a migraine headache. Migraines tend to be unilateral in adults. They're bilateral in children. And then you can have a cluster headache, which tends to be behind the eye, and they come in clusters. You might not have any for 6 months, and then you have 4 or 5 in 2 days. So they come in clusters. The other thing is you can have a tension headache, which starts on the trapezius and goes up the occipital area, both sides. You can also have a hypertension headache. When you have high blood pressure, you're also going to have a pulsating headache. Okay, and with that, some people will say they hear their blood pressure, they hear their pulse in their ear, and that would be typical of a hypertension headache. You've got different facies or facies that if you look at page 246 to 248 in your book, you've got a lot of those listed. And from Cushing syndromes, and you've got the pictures of them and the descriptions in your book, and the fetal alcohol syndrome. And they really tell you in the book what you're really looking for. Okay, parotid gland tumor is where you're going to have that. And now this can be right at the temporomandibular joint area and a little lower, below the mandible. Paget's disease of the bone is where you've got bossiness of the bone, and this lady's got it in her forehead. And this is a typical Paget's. Bell's palsy is another facial abnormality. This is on this lady's left side. And you see that she's smiling, but the left side doesn't move. What you want to note is this only from the cheek down. That's going to make you think it might be trigeminal versus Bell's palsy. If it's the entire face, and it's not on this lady because you notice the eyebrows are symmetrical, and if they didn't blacken the eyes, you'd notice the eyes look symmetrical. But if it was all over one side of the face, you would think more of TIA or stroke. But on Bell's palsy, it tends to be just on from the cheek down. And this is something that you can rapidly treat with steroids and make a real difference in the people. Other common abnormalities of the neck is a thyroid glacial cyst. And if you will look in your book, you've got good pictures of that. You can have a brachial cleft cyst. You can have wry neck. And you've got a picture of wry neck in your book also at the end of the chapter. And a salivatory gland tumor. Now that's sometimes hard to tell the difference between a parotid tumor and a salivary gland tumor. And how you do that is the salivary gland tumors often are bilateral, more so than the parotids. But either one, you're going to go ahead and just look at the size, see how thick it is, if it feels irregular, and you would do a soft tissue CT with contrast to be able to tell what kind of tumor you've got there. And some of the things they used to do on the head, like percussion of the head, they don't do that as much now because of the commonality of CT scans. But to tell a salivary gland tumor, you would do a soft tissue CT of the neck. Okay, common abnormalities, thyroid glands. You can have hypothyroidism, where your thyroid's underproducing, hyperthyroidism, myxedema, Graves' disease, which is also hyperthyroidism, and Hashimoto's disease. Now, what's the difference between hyperthyroidism and Graves' disease is often for many splitting hairs, but Graves' disease has been there for a very long time, and it tends to have more irreversible components to it. Hyperthyroidism might be a slight hyperthyroidism, but Graves' disease tends to be around longer. But hyperthyroidism and Graves' disease are essentially the same thing. Infants and children, they can have an encephalocele, they can have microcephaly, they can have craniostenosis where the suture lines of the skull becomes fused. And they can have, it's common that they have bruits in their anterior fontanelle, or you're going to hear bruits in the kids over the fontanelles until 5 years old. That is not a big deal. You want to just really watch the head circumference on these children. You can percuss the skull with one finger to detect if it's got McEwen's sign, and that's a stronger resonant sound with either hydrocephalus or brain abscess is present. But that's not done near as often now because you're doing a CT. Thyroid may or may not be palpable on infants and children. On this little boy, you see that he's got Down syndrome. The biggest thing that jumps out at you is the bridge of the nose is almost non-existent. It's just really decreased. He's got the Mongolian slant of the eyes. And if you were to look from the outer canthus of the eyes towards the upper pinna of the ear, you're going to realize that the ear, if you were to turn this head sideways, it would probably be right, barely touching the ear or a little low. And he has a large tongue, and that's often common because the mouth is always open and the tongue is partially protruding. On this fetal alcohol syndrome, there's two things that are just classic. You're going to notice the wide bridge, the wide set eyes. They just hit you as pretty wide on the face. The other thing that you're going to know is he has a poorly formed philtrum right here underneath the nose, the little bridge in the middle of the upper lip. You just don't see it very much. And he's got a short nose and a relatively thin upper lip. Classic alcohol syndrome. And this is one of the most common acquired mental retardations is due to fetal alcohol syndrome. Okay, the heads. I went ahead and talked to you about migraines, unilateral in adults, bilateral in kids. And 50% of the adults with migraines, their children, will have migraines. They come in clusters, are often behind the eye. The bad thing about cluster headaches is people get very frustrated with them, and it has the highest suicide rate out of all these headaches. But the good thing is that they're usually treatable with high-dose oxygen. But this is not a normal oxygen container. It has to go up to 12 to 15, instead of just the typical 5 that you see in the hospital. They'll go up to 5 liters. But these that you would treat a cluster go up to 12 to 15 But once the people realize how the oxygen can make a difference, they will love you for writing that prescription. Hypertensive, it's pulsating. They often hear it in their ears. Muscular or tension headache starts in the occipital and moves up. Temporal arthritis is only over the temporal area, and it's more painful with palpation, where you tend to rub your temples just to relax sometimes. That is where the temporal arthritis will be. And the salivary tumor, the salivary gland tumor is a tumor of any of the salivary glands, but most commonly in the parotid. They're slow growing. Another one of the facial things that we notice is a butterfly rash of systemic lupus erythemus. And it's a butterfly rash that goes over the nose and over the cheeks. And this little girl's got one. This picture's got a little bit of glare on it. Okay, thyroid glossal duct cyst is a palpable cystic mass in the neck. You can have a brachial cleft cyst. It's a congenital neck formed by incomplete involution of the brachial cleft. And then you can have wry neck, birth traumas, tumors, and or just trauma, cranial nerve palsy, muscle spasms, infections, and drug ingestions can all lead up to wry neck. Okay, hypothyroid is the underactive thyroid. Hyperthyroid is overactive. And myxedema is skin and tissue disorder, usually due to severe prolonged hypothyroidism. And it's sad because it's something very treatable. All right, here's the thyroid enlargement that's not so obvious. And this is a typical thyroid enlargement in pregnancy. Why do you know that this is abnormal? The left is bigger than the right. Thyroid size increases in pregnancy in areas of iodine deficiency, but not in those with sufficient iodine. In the United States diet, most of the iodine is put into salt. And it's in the countries where the salt is harvested from the sea and there's no iodine added that it's notorious for iodine insufficiency. Iodine is also very high in shell, seafood, shrimp, lobster, that kind of stuff. Things that come in shells. All right. Myxedema facies, it's the puffy yellowed skin on this Hispanic-looking man. And it has sparse hair and temporal loss of the eyebrows, but his look pretty thick. Okay, here's the hyperthyroid facies. The problem with this, bless this lady's heart, she will never get her eyes back to normal. She has eyelid retraction that is permanent because this was not detected early enough. Now, how do you know that this is eyelid retraction? Because on the eyes, and when I talk about eyes, I'll bring this out, but you should not be able to see the sclera all the way around the iris. You can see one or the other, but on most people, you cannot see both. Now, those from the Mediterranean, you'll be able to see the sclera around the iris, or the white part, all the way around the colored part. But most Caucasians, you're going to see the lid goes on the iris on both the top and the bottom. And that's going to be your first clue. If you can see anywhere, can see the sclera all the way around the iris, or a good part of the iris, that should be letting you know that there's some eyelid retraction. Okay. Graves' disease, autoimmune, and antibodies to the thyroid stimulating hormone receptor, and it leads to an overactive thyroid. And Hashimoto's disease is also autoimmune antibodies against the thyroid gland, and it often causes hypothyroidism.